We all know artificial intelligence is poised to completely change medicine, but there is one massive hurdle we have to get over first: trust, right? How do we actually make these incredibly powerful AI models safe, fair, and reliable enough for a doctor to use with a real live patient? Well, in this explainer, we're going to break down exactly how.
Okay, so imagine you're a doctor working in the ICU. An alert suddenly pops up on your screen. An AI is predicting your patient has an 87% risk of a major bleeding event. Now, that is a powerful and kind of scary prediction, but it's not enough. The very first, most important question you're going to ask is, why? And that right there is the core of the problem. An AI that just spits out a number without any reasoning is what we call a black box. And when someone's life is on the line, a black box just isn't going to cut it. So let's break down the 4 key pillars of building a system that doctors can actually rely on.
So our very first step has to be cracking open that black box. We've got to give doctors the tools to understand the why behind every single prediction the AI makes. The main tool we use for this is called SHAP. Now, it sounds super complex, but the idea is actually borrowed from game theory, and it's pretty intuitive. It basically treats every piece of patient data, their age, medications, lab results, as a player in a game. The goal of that game? To predict the patient's risk. And SHAP's job is to figure out exactly how much each player contributed to that final score.
So think of it just like this. You've got a whole team of players, and that's all the patient's data points. The game is predicting their risk. SHAP then meticulously calculates how much each individual player, each piece of data, actually changes the final outcome. So the final risk score you see is literally just the sum of all those individual contributions. And this is where it all clicks. This slide shows how a prediction becomes totally concrete. For this particular patient, the average or base risk is about 12%. But they're taking the blood thinner warfarin, boom, that adds 28% to their risk. They have a high INR lab value, that's another 22%. Their age adds 15%. All of a sudden, that scary black box number of 87% becomes a clear, understandable story that a doctor can see and immediately act on. But, knowing why is really only half the battle. The doctor's very next question is, okay, what can I do about it? And this is where we move from SHAP, which is diagnostic, it tells you what's wrong, to something called counterfactuals, which are prescriptive. They answer the what-if question.
And here you can see the incredible power of a counterfactual in action. The AI doesn't just scream high risk, it provides a clear, actionable plan to get that patient's risk below a much safer threshold. This is what transforms the AI from just a simple alarm system into a true clinical co-pilot.
So we can explain a single prediction. That's a huge step. But it naturally leads to an even bigger and maybe more important question. Does the AI work equally well and fairly for every single patient, no matter their background? This is the really critical problem of algorithmic bias. As this chart shows you, a model might look fantastic on the surface with 90% overall accuracy, but when you dig just a little deeper, you can uncover a really dangerous inequity. In this case, it's 92% accurate for white patients, but it drops all the way to 78% for black patients. That's not just a statistical error, that is a serious patient safety issue. So to fix this, we need a much better way to measure fairness. In healthcare, a really important metric is called equalized odds. This basically ensures the model has the exact same error rates, both for missing real problems and for flagging false alarms, across every single demographic group. The model must be just as reliable for a black patient as it is for a white patient. No exception. And the good news is we have several strategies to actually fix this bias. We can adjust the data before we train the model, we can build fairness constraints directly into the training process itself, or we can even adjust the output thresholds after the fact to make sure those error rates are balanced for everybody. Okay, so now we've got an explainable and a fair model. We're done, right? Well, not so fast. Medicine is constantly changing. So the next critical question is, how do we make absolutely sure our AI stays accurate and reliable, not just today, but next year and the year after that? This is the huge danger of what we call concept drift. A model trained on data from 2022 might be 90% accurate at the time. But then, as this timeline shows, something in the world changes. A new virus emerges, a new drug hits the market, clinical guidelines get updated, and silently, without anyone even noticing, the model's performance can just decay, becoming dangerously out of date. So how do we detect this silent decay? Well, we use statistical tests like the Population Stability Index, or PSI. Think of it like a smoke alarm for your data.
A PSI score that creeps over 0.25 is a major alarm bell. It's telling you that the patient data coming in today looks significantly different from the data the model was trained on. It's a clear signal that it's time to retrain.
And this is what it looks like in practice, a live monitoring dashboard. Engineers can see not just that, hey, performance is dropping for young adults, but they can see exactly why. Look, the PSI for a new drug is through the roof. That's a massive red flag signaling a huge shift that the old model just doesn't understand.
So we have an explainable, fair, and resilient model. But to keep improving it, to make it even smarter, we need more data. And that, of course, brings up huge questions around patient privacy.
A really elegant solution to this problem is something called federated learning. Instead of all the hospitals sending their super-sensitive patient data to some central server, the AI model itself is sent out to the hospitals. Each hospital then trains that model on its own private data and sends only the mathematical lessons learned, not the data itself, back to the central server. The result? A smarter global model that learns from everyone without ever compromising patient privacy. It's pretty brilliant.
Now, let's look at one final and frankly critical threat: AI hallucination. A large language model might confidently generate a recommendation just like this one, telling a doctor to combine two powerful drugs that together dramatically increase bleeding risk. This isn't just wrong, it's potentially lethal. The safeguard against this is a system called Retrieval Augmented Generation, or RAG. It's a simple but incredibly powerful idea. Before the AI is even allowed to answer a question, it is forced to first go look up the relevant facts from a trusted, verified source, like a medical knowledge base. This grounds the AI in reality, and it stops it from just making up dangerous fiction.
So you see, building trustworthy AI isn't a one-time fix. It's a continuous process of asking the right questions over and over again. We've asked why, is it fair, and will it last? The real question is, as this technology becomes a true partner in patient care, what are the crucial questions we all need to start asking next?